Hi, my name is Kathleen Berkowitz, and I will be talking with you today about the diagnosis and initial management of gestational diabetes. Now, this may seem like a fairly narrow topic, but as you'll see, there's a lot of detail and a lot of controversy about some of the diagnosis and management steps, which we'll be going over today. So thank you for joining. The disclaimer is that, this is a resource. It doesn't define the standard of care. You will be taking these guidelines and adapting them to your local facility level of care. I have no conflicts to disclose, and we will be moving on to a very famous man who you may or may not recognize. And I think that I put his picture up here mainly because he had a couple of very funny sayings that I think really apply to both this lecture and the next lecture I'll be giving you as well. One of them, which I think applies very well to the diagnosis of gestational diabetes, is you got to be very careful if you don't know where you're going, because you might not get there. And a quote of his that I like that applies to initial management of gestational diabetes: when you come to a fork in the road, take it. And of course, this was Yogi Berra who said these things. I hope that I will be much clearer than that and give you a series of good signposts to follow during the diagnosis and initial management of gestational diabetes. Our objectives are pretty broad, as you can see. First, we want to understand what the clinical goals are for managing a pregnancy complicated by gestational diabetes. We want to review the maternal and neonatal complications that we're trying to prevent. Again, we'll get into the wilderness of differing screening recommendations, which I will urge you to take down to your local level and make sure that you are all speaking the same language, because patients will pick up very rapidly on any clinical differences that your members of the team have. We'll talk about the classification of diabetes, which is a little bit easier. We'll look at some of the targets and some of the ranges and what is normal in a pregnant woman who has a lean body mass and doesn't have diabetes. Very important to review medical nutrition treatment, because this is really a keystone in both achieving good outcomes and in educating your patient on the interaction between diet, exercise, insulin, and weight gain. We're going to look at the medical management from my point of view as an initial consultation that I hold with a patient, to how I code it down for a clinician to look at what we're trying to do in the first trimester, second trimester, and third trimester. We'll look specifically at the complications in each trimester. And then I really do want to leave you with the importance of the role of the team in managing this and in telling your patient what your initial steps are and what your ongoing steps are going to be as well. Making this simple, the goals here are, if you're a mom, you want to have a simple pregnancy. And in an ideal situation, you're going to want to try and learn information that will prevent long-term medical complications. From a baby's point of view, you want to be born on time. You don't want to be born injured. And again, you'd like to have an uncomplicated childhood and early adulthood. So those are really the goals that we're speaking about for management of diabetes. The diagnosis is of concern because of these complications. And the important part here is I want to start by looking at what would happen to mom and what would happen to baby if the diagnosis was not made and no treatment occurred. A little bit difficult to do in our clinical milieu now, but there are some studies that help inform us about these issues. So from a maternal point of view, why is the diagnosis of concern? Well, one of the most common complications is not necessarily just a big baby. It's the increased risk for hypertensive disorders, especially during the third trimester of pregnancy. And as those fasting glucoses increase, the risk for preeclampsia and the other hypertensive disorders of pregnancy also increases. So that you can see that, if your fastings are under 115, certainly not ideal sugars, but this is where the study put them, the risk is around 9.8%. If your fastings are consistently over 115, your risk doubles for getting a hypertensive disorder in the third trimester of pregnancy. You get an increased risk for cesarean section. again, from 9.5% on the control population to about 25% with medications. Again, these local numbers are going to vary wildly from place to place. Again, moving on to the lifetime risks, up to 50% of women are going to develop type 2 diabetes if they have had a diagnosis of gestational diabetes during their lifetime. This is a golden opportunity from a public health point of view to try and put some education into place that might help modify that lifetime risk. And for some subgroups, the risk can be as high as 60%, and the time period to development of type 2 diabetes can be as short as 5 years. So this would be a subgroup that we would want to identify and really put a lot of public health resources into. This slide, maternal complications, is really just to sort of simplify what I'm talking about. I know some people like words and some people like graphs. I find graphs very helpful for talking to patients, and so of course I've colored the moderate to severe range orange to sort of depict that higher level of danger. But again, just graphically, what I'm showing you here from a selected set of data off of the ACOG Practice Bulletin 180 is the increased risks for preeclampsia, cesarean delivery, and lifetime risk for type 2 diabetes. The other thing that's important is there's no point diagnosis list of what can and can't be accomplished with treatment during pregnancy. And then the U.S. Preventative Task Force Review is another very big study. All of these show that you're going to be able to decrease selected complications, from neonatal complications to maternal preeclampsia to not consistently, but you can decrease cesarean section rates in some studies. And so now that we have some very big landmark studies that show that we can decrease the risks for complication, it makes sense to pay attention to diagnosis and to treatment. From a neonatal point of view, this one is another landmark study looking at patients with mild gestational diabetes, randomized to usual care versus what we would now consider usual care, which is diet, exercise, and home glucose monitoring. And again, this could only be accomplished in patients with mild gestational diabetes. Nobody was going to randomize patients who are clinically usually being treated with medications. But you can see that the birth weight with treatment was slightly lower. The risk for a large for gestational age infant was significantly decreased. The risk for NICU admission was significantly decreased, and so was and then the risk for respiratory distress syndrome, which is a rarer complication, was also decreased as well. Again, speaking to the need to treat these complications. In this same study, we were looking at maternal complications. Cesarean section rates did decrease. So did shoulder dystocia rates. The risks of development of any of the hypertensive diseases in pregnancy, preeclampsia, or gestational hypertension also decreased. And with treatment, you can also see that there was an effect of a lower weight gain in pregnancy, which probably reflects the fact that these patients were getting good nutrition and dietitian care. Okay, so now that I've shown you that we have a disease and that treatment prevents complications, let's talk about the various screening strategies that are out there. And here are some of the controversies with this. Do you screen everybody universally, or do you just go for a targeted population? The problem with a targeted population is that you may miss people who you should have targeted. The problem with universal screening is that you may diagnose somebody for whom the disease is either mild or minimal. When do you screen them? When do you repeat it? Do you use the one-step or the two-step? We'll be going over that in a minute. And then which criteria to use? The International Association and Society of Diabetes and Pregnancy Group, American Diabetes Association. Do you use Carpenter and Kustan? Do you use something else? I have seen labs that are using local issues. And so this is an issue as well. American College of OBGYN, the most recent Practice Bulletin 190, came out in February of 2018. And specifically states no one strategy has been shown to be superior. So pick just one and stick to it, again, locally, what works with you and what your group and your team can agree to. As for when you do the screening and who, again, we're looking at some of the advice that are in the most recent bulletins from Diabetes Care and American College of OBGYN. If you are looking at targeted screening early, here are the groups that you would put into that high-risk screening visit. Body mass index greater than 25, greater than 23 in Asian Americans, those with physical inactivity, first-degree relatives with diabetes for that patient, prior big baby, prior gestational diabetes, hypertension, the diagnosis of impaired glucose tolerance, prior diagnosis of PCOS, anything with low or high triglycerides, any history of cardiovascular disease, and then any high-risk race or ethnicity, which you can see is also a very long list. If you're considering all of these patients to be high risk, you're going to find that you're going to be screening a large proportion of your population at that first visit. And so we'll get to what those screening efforts may look like as well. Another way of looking at this, and this is what we evolved from, this is the 2010 guidelines that a lot of us who've been doing this for a while were familiar with in the last decade. Risk assessment at first visit. If you're low risk, which was somebody under the age of 25, didn't have any family or personal history, no ethnic risk, not obese, no poor OB history, that person was low risk and didn't need any screening. Patients at average risk got screened at 24 to 28 weeks, which is that time when insulin resistance begins to increase. They were defined as those who were either not at high or low risk. And then the high risks were those who had elevated body mass index, strong family or personal history, or glucosuria. So this was the approach that we worked with in the 2000 to 2010 era. And then because I was working in California for a very long time, we had localities with extremely high prevalence of impaired glucose tolerance and overt but undiagnosed diabetes. And so in those localized areas, we would do universal screening of all patients at the first visit. That was our local modification of that. Now, this gets to be very cumbersome, especially at that first visit when you're talking to somebody about her ultrasound and her dating and her genetic screening, and does she want first trimester screening, and when is her next visit. So by the time you get through all this information, it can be very difficult to get a patient to get screened at that initial visit. This is one of the reasons that I'll show you what my local modification was on it, but first let me go over what the IS There's a two-step method, which we are most familiar with in California and in the U.S., where a patient is given a 50-gram glucola load. 1 hour later, she is screened. You can use 130, 135, or 140 as your cutoff value. The advantage to that is the patient does not have to be fasting for that. And then if she goes over your cutoff value, you perform the 3-hour test. So that's the two-step method. If you're going to be doing the two-step method, one of the things that you should be doing is doing a 3-day unrestricted diet, carbohydrate rich, overnight fast, and then you get the fasting level, and then you check the fasting level. If the fasting is over 125 milligrams per deciliter, not a good idea to perform a 3-hour 100-gram glucola administration. At that point, you would say, hey, you know, she meets the ADA criteria for overt diabetes. Let's call the doc and see if they really want us to do this. Not many labs are actually doing this before they administer the 3-hour test. For patients who've had a gastric bypass, a method that has been popularized is either the mixed meal method or the jelly bean test. You got to be a little careful with the jelly bean test because it is still an osmotic load for a patient with gastric bypass. Now, locally, what a lot of people have done is they have simply added a hemoglobin A1C to their initial visit OB panel to determine who's got overt diabetes. And that was the local modification that we used in California where I was working for several years. If you are using the 2-gram, 1-step, 75-gram method, the numbers are any one of these 3 that are abnormal will buy you the diagnosis of gestational diabetes. And the numbers are 92, 180, and 153. No, they are not 90, 180, 153. In order to get the proper sensitivity of the test, it's 92, 180, 153. So not necessarily easy to remember, but that is what you would use and what your lab should be using if you're using that 75-gram test, either prenatally or in that postpartum period. If you're using the National Diabetes Data Group or the American Diabetes Association numbers, here are the Carpenter and Kustan numbers, and then looking at the older numbers from the O'Sullivan studies, you'll see that those are a little bit different. 95, 180, 155, 140 for the Carpenter-Kustan. Any 2 of those abnormal will give you that diagnosis. O'Sullivan, same thing, different numbers, but any 2 abnormals gives you the diagnosis. This is another way to screen. Now, screening strategies, again, this is what was recommended back in 2010, and so this is familiar to a lot of us. At the first prenatal, just check a fasting, a hemoglobin A1C, or a random glucose, either on all patients or only your high-risk local group, depending again on what the frequency of abnormal glucose metabolism is in your local population. If your fasting's over 125, just call it overt diabetes. If it's 92 to 125, call it gestational diabetes, understanding that she really probably has impaired glucose tolerance. And if the fasting was 92 or less, then test again at 24 to 28 weeks. This is a fairly cumbersome way of testing. It didn't get a lot of traction clinically. And again, recommendations have changed a little bit since that March 2010. But that was what the history that we've evolved from is. And here's one of the reasons why we've evolved in this, because if you look in the bottom right-hand corner at what the diabetes rates were in 2010 compared to the bottom left-hand corner, what they were in 1994, you'll see that the prevalence of both the obesity, body mass index over 30, and the rates of diabetes have significantly increased in every state. The Southeast is, of course, the epicenter of all of this, but you can see that the colors on the map have just deepened as the decades have gone on. And I'm certain that the next time this map comes out, you'll see even higher prevalences. Because of this increasing background prevalence of obesity and undiagnosed diabetes, this is why the screening strategies have evolved to what they have in 2018 and 2019. If I can give you some clinical advice, just again, practicalities. If you're working in a high-risk, high-prevalence population, which, as I showed you, most of us are these days, just screen everybody at the first visit. From a point of ease of your patient, you can get a hemoglobin A1C without having to do every single first prenatal visit for somebody who's fasting, and then trying to get through the rest of your clinical visit and all the other things you have to do in your first visit. You can't do that when somebody's fasting and expect them to listen to you. So a practicality I would suggest for high-risk areas is just screen everybody at the first visit with a hemoglobin A1C. That identifies that targeted population that most urgently needs treated, those that had overt but undiagnosed type 2 or type 1 diabetes. And then at 24 to 28 weeks, pick one of those screening methods, the one-step or the two-step. And if you're going to stick with this two-step, decide whether you're going to stick with Carpenter-Coustan or O'Sullivan. Use that consistently in all your patients, whichever method you have chosen. Make sure that your team and any consultants that you know that are going to be on the team know the criteria for diagnosis and are in agreement to you. The most frustrating thing that can happen to you is you can tell your patient that she has gestational diabetes. You send her to an endocrinologist and he says, nope, she doesn't. And then the patient is very confused. So you want to make sure that everybody on your team is on the same page so that you keep the education needs of your patient as streamlined as possible. A few other practicalities. If your 1 hour screen is over 200 milligrams per deciliter, more than 90% of those patients are going to have a positive 3 hour. So I usually recommended that my referring physicians just got a fasting sugar the next day, and that would help us figure out who needed a streamlined referral for initial therapy within the week, and in those very rare situations, who would need hospitalization for control, especially in the third trimester. And we'll go over that subgroup a little bit more in a little bit later in this lecture. If your fasting's over 140, that is a group where you may want to hospitalize them for rapid restoration of good glycemic control and an intensive knowledge therapy. You must really cone down what your goals of therapy are during hospitalization if you wish to avoid a 7 to a 10-day hospitalization. Your goals would be specifically this: make sure she doesn't have DKA, make sure she knows how to do insulin, make sure she knows how to treat hypoglycemic symptoms, and make sure she has all the therapies that she needs and phone numbers she can call for that first week of therapy. Those would be my goals for a hospitalization, and not a goal of get perfect control, which as soon as she goes home and changes her diet, you'll see that change as well. Now, as for classification, that is a little bit simpler for gestational diabetes. It's diagnosis or first recognition of diabetes during pregnancy. A1, no fasting value greater than 105 milligrams per deciliter. Again, this is the O'Sullivan criteria. Class A2, at least one fasting value, whether it was on that 3 hour or subsequently, that's over 105. Those patients may end up being diet controlled about a third of the time in my experience. The rest of them are probably going to require medication, and of course our primary recommendation now is going to be insulin. If you have someone with either a fasting of over 126 or a hemoglobin A1C of 6.5 or greater, then you can refer to the ADA 2019 Standards of Care. Just say, these are patients with overt diabetes. Let's just move on with planning diet, exercise, home glucose monitoring, and medication for that group, which would be insulin. Now, what do I do if I find someone who I truly believe had diabetes prior to pregnancy? Well, about 15% of these patients will have thyroid disease, and if your thyroid disease is not well controlled, I can't well control your sugars, so I put a TSH into that. A lipid panel is recommended. Doesn't make too many differences in our clinical management during pregnancy, but certainly can help stratify those that are going to be at higher risk for complications long term. And again, the hemoglobin A1C. An eye examination is really important, especially if the patient is hypertensive or proteinuric. If they are not, then retinopathy is fairly rare, but again, that helps you stratify who you need to streamline for eye examinations. Baseline blood pressure is very important because without knowing what the baseline is, I can't tell you whether or not you have preeclampsia later. Same thing with a 24-hour urine collection. If I don't know what your baseline is, I can't tell you if it's preeclampsia later. I do reserve the EKG for someone who already has hypertension or is over the age of 35 as a screening test. And then, of course, we're going to start asking her to do a bunch of things. And so in order to help her understand why we're doing this, confirmation of a viable pregnancy. The numbers for any pregnancy are 20 to 25% of pregnancies don't make it out of the first trimester. And so if you're going to be putting all these lifestyle modifications into place, it is nice to make sure you've got a viable ongoing pregnancy. In my initial consultation with the patient when she's referred to me, I will go over for her, I will elicit from her what she understands about how she was diagnosed and what knowledge deficits she has for that, because this is the most important step. If a patient doesn't believe she was appropriately diagnosed, she is not going to believe that she needs therapy. And so spending some time on this with the patient for me is probably worth 5 or 10 minutes right there. Then I'll go over what she knows about the complications associated with diagnosis, and if she's missed any or has some ideas that are out of the mainstream, I'll be able to elicit those things then. And then sit back, ask her what questions she has about the diagnosis. And you're going to have to let her do some free association here, because listening to how she speaks and what questions she has will inform you about what her educational needs are. Once we get through that, I'll go over what the goals of therapy are. And again, I will have reviewed those with my team to make sure we're all talking the same goals. And then what I think is another extremely important part of this is to assess what barriers she has to how her day goes, whether they're family, travel, transportation, work. What are the barriers that she sees to initiating what I'm going to tell her to do? Because I'm going to be telling her to eat 3 times a day, snack 3 times a day, walk 3 times a day, check 5 times a day, and probably take medication as well. So I would find that very difficult to do on a daily basis. And so knowing where my patient's reasonable expectations are of, you know, I can do it at this time, but I can't do it at that time, that helps me help her figure out how to get under good control. And then I'll set with her a time frame to review how long we're going to see how this initial therapy works and when I want to see her back and why. From the patient's perspective, here are things that I think are really important to elicit. Many patients are afraid of this diagnosis, and fear leads to denial, and denial leads to inability to treat, which leads to frustration from your patient's point of view because you're not recognizing her fear, and frustration from your point of view because you're not recognizing why she's not compliant. Family input is huge in this. If most of these patients will have a family member, if not an extended family member with diabetes, who isn't pregnant, who may have a hemoglobin A1C of 9, and who may have the impression from their doctor that that's fine. Or they may have the 80-year-old grandmother who gets hypoglycemic and will fall down and break her hip. And they will be telling her that the numbers that you wish her to achieve might be dangerous. And so you really have to review what her family input is and ground her in what the pregnancy goals are. Change is hard. If change was easy, we'd all be marathon runners with a body mass index of 21. Very few of us are. And so acknowledge what that resistance to change is. See what her current state of knowledge is, figure out what her biggest knowledge deficits are and work on those first. Acknowledge what she's been able to do and help her reward that. One of the things I tell my patients to do is at the end of the day, sit down and look at the one thing they've done right. I want them at the end of the day to find one thing that they did correctly and say to themselves, tomorrow I'm going to do that again. Most of us will sit down at the end of the day and go, oh, I messed up here, I messed up there, and focus on what we've done that's negative. I'm trying to get them to focus on what they've done that's positive and build on that. That seems to work for me and my patients better than focusing on the negative. Complications including adult respiratory distress syndrome, development of preeclampsia, which may require induction of labor. Induction of labors fail and can lead to cesarean sections. And then again, the fetal things, the increased risks for malformations and stillbirth. So moving on to that, I want to talk about what is optimal control. Optimal control is that which, and this sounds simple, optimizes glucose control and weight gain. Exercise is an important component of that. You've got to check your fastings. You've got to check your post meals. 1 hour or 2 hour, again, that can be something that you look at locally. Weight gain goals, what your calories are per trimester. I know we've all had the experience of taking care of the 12-week pregnant patient who's already gained 15 pounds. Caloric distribution and carbohydrate intake, again, that 40-40-20 is a very good general guideline for starting for that. But you must talk about glucose and weight gain and exercise, not just glucose control. Now, I want to refer here, and I use this as a baseline for my patients to sort of counteract that family input that I talked about. This is a study out of Italy in lean women who had an average BMI of 21, as you can see, who gained 20 to 25 pounds of weight during the pregnancy, and looking at what their normal sugars were. These are non-diabetic patients. Their normal mean glucose was 71 to 78. Their normal fastings were 56 to 60. Normal 1 hours for this group was 115. Now, I've seen the study done with people with higher BMIs too, and the normal fasting glucoses are 60s to 90s. The normal post meals are, again, pretty much in that same range. So I wanted to use this as a historical reference. Yes, it is in lean women. It is not that much different for women with higher BMIs. But that's what would be normal in pregnancy for a patient who does not have diabetes. Now, we don't need our patients to get down to normal entirely in order to minimize their complications, but that's what I start with when I talk to them in my initial consultation. Then we talk about how well is she going to be able to follow the dietary recommendations. Let's be realistic as opposed to simply optimistic. Performing home glucose monitoring, what are the barriers to that? There are all sorts of ways to link glucose results to dietary intake. Lots of yes, you're seeing a whole bunch of other patients. But I think the key here is you need to find a way to help your patient translate those carbohydrate, fat, protein ratios into an actual meal plan that looks like a plate that she can eat, that fits her food preferences, and something she can do. It should be divided into 3 meals and 2 to 3 snacks. But helping her visualize her plate is probably the most important part of this. Here are a bunch of resources for that. There's California My Plate, which I like a lot. There's our Sweet Success Food Guide. ADA has Create My Plate. There's a bunch of other online apps, and I'm not reviewing those at this. Journaling, one of the things I've had my patients do is either use their notes function or actually literally just take a picture of their plate and bring them into my visit so I can look at what they ate. Meal cards for fast food restaurants, I find that those are handed out at the fast food counters easily. And then if you're lucky enough to have an electronic health record, there's a lot of communications functions. Epic has one. Cerner Health has one where you can use things like MyChart to communicate directly with your patient without anybody having to travel. So those are just some of the resources you can use to improve those dietary goals. Exercise is important. Ideally, 30 minutes moderate intensity aerobic exercise at least 5 days a week, or a minimum of 150 minutes per week. This is exactly what my Fitbit tells me to do. Do I get it every day? No. If you have to cone down to what is most important is exercise after meals, because that will decrease those postprandial glucose values. This is a slide which Trudy Theis has agreed to share with me, and you can use this visually to show your patients what her glucoses are going to look like if she walks versus not walking. And you can see with the blue line there with walking, you can see that there is a lower blood sugar peak and that it is removed more quickly from the system. It's because your muscles are using this up. So I really appreciate being able to use this slide and show my patients the impact of walking. Now, weight gain. Education, dietary counseling, home glucose monitoring, exercise, all of these things are important. But the patients do need to understand it's not just glucose control. If you gain 50 pounds, you're still going to have to deal with risks for a big baby, weight to lose afterwards. If you manage to optimize your weight gain, you'll see decreased rates of macrosomia, improved postpartum weight loss, lower rates of depression. So it is extremely important to focus on this. This is the Institute of Medicine criteria for patients with a low BMI and with a high BMI. I have even seen 5 to 15 pounds for somebody who's got class 2 or class 3 diabetes. And achieving those weight gain goals is associated with lower rates of preeclampsia and lower risk for cesarean section. So it is very important to focus on weight gain. Here's a really nice study by Mastrogiannis that came out about 10 years ago, looking at the effect of excessive weight gain. Now, this is for obese women whose body mass index was over 30, who were well controlled. And then he split them out looking at what outcomes based on weight gain. So you can see if somebody gained 40 pounds, their cesarean section rate was up to 73%. Up to 11% of the babies ended up with neonatal hypoglycemia, and almost a quarter of them ended up in the ICU for at least a short-term admission. And that was in women who were well controlled otherwise, just stratified by weight gain. So weight gain is important, and again, points to why you need to have a dietitian on your team. You need to tell your patients why she's got to check her fastings and why she's got to check after meals. Those 1 hour after meals correlate with lower rates of large babies, lower cesarean section rates. So the question becomes, do you have them do 1 hour or 2 hours? Again, I think that is a local decision, depending on what you and your team feel. I understand that 1 hour is a better physiologic measure, but it may not fit into your patient's lifestyle. And so if she needs 2 hours and that's all she can do, because that's what fits her break schedule, then I'll adjust and work with that. Here is another very important landmark study that came out of University of California, Irvine, back in the day, looking at, these are patients who were randomized to just checking pre-meals or checking their post-meals, and then having their glucose control adjusted by what those values were. And for those who did post-meal monitoring, there were significant decreases in a number of complications. Again, you got to do post-meals. As for rational goals of therapy, I really, again, I'm trying to break this down into practicalities because you can get in too many fights over numbers. There's 3 categories of patients clinically, in my opinion. Those whose fastings and post-meal values are in a range where the majority of studies show low complication rates. Those whose values are consistently in a range that everybody agrees have increased rates of complications. And then there's that group that I call the battleground, where you can get 6 experts to show you 7 studies that show 8 different things. And we'll talk about that in a minute. What I think is important here is that the HAPO study showed us that these rates of complications increase in a continuous fashion. So there is really, it's difficult to figure out what your specific best numbers are. But here's the general categories. Everybody agrees this group is doing well. Your fastings are under 90, and your after meals, whether you're using the 1 or the 2s, less than 120. Pretty much every clinician I know is going to say that patient's doing well on DEXA, diet and exercise. I will say that American College of OBGYN and the ADA set this target at 95, but in my experience, there's large groups of clinicians who really feel that that 90 to 95 range may not be appropriate and may need tighter control. Everyone that I know is in agreement that you need tighter control if your fastings are consistently over 105, your post meals are consistently over 140. So again, this leaves us the battleground patient, and this is where you and your team need to be on the same page so that your patient gets a consistent message about what you're using. Now, how low can you get the complication rates? Well, I'll tell you what you can't do. You can't get to 0. The HAPO study is probably the largest one of these, 23,000 participants. Here's their criteria, untreated, and what you essentially saw was gradually increasing rates of primary cesarean section rate as the fastings went from 75, which is pretty normal in the lean patient, to 100 milligrams per DL. No consensus on when that increase became clinically significant. So you talk about this with your patient. And here's the way I would like to see a note set up, because I feel this is what's helpful to my referring physicians. You know, when she wake up, when she have breakfast, when she have her snack, when is and I start with the diet and exercise patterns, because you cannot get consistent results without having consistency in these items. How often is she monitoring? What barriers exist to improving monitoring? I picked a patient's monitor up this week, and she had a beautiful log, 35 different measurements, and I picked up her meter, and her meter memory said 11 measurements in 14 days. At which point I said, do you have another meter? And she's like, no, this is what I guessed my numbers were afterwards. And she did it with great intent, but we went through the fact that that actually wasn't helping me get her to the best goals. Is she reaching her targets? Low readings, any changes in therapy that I'm recommending that she thinks she can put in, and when I want to see her next. So this is helpful to my patient if she's going to be reading it in an electronic health record, and it's helpful to my referring physicians. Now, moving along to sort of what our conceptions, our goals of therapy are based on time periods. Again, gestational diabetes is recognized later, but preconception goals are universal for many women. And one of the preconception goals that I would recommend is that you see your doctor before you get pregnant, simply to make sure you don't have anything like overt diabetes or hypertension or other things that need to be addressed that would be barriers to getting through that first trimester. And then we'll go through first, second, and third trimester, and then for bonus points, some of the postpartum and long-term goals. Again, we'd like to prevent miscarriage. When very early pregnancy is identified in a setting of poor control, this is a situation where you might want to consider hospitalizing someone, because rapid normalization of control may improve that pregnancy's survival rate through the first trimester. Again, may improve. You would like to prevent ketosis. So if someone's got hyperemesis and is unable to keep anything down, that is especially bad in the overt diabetic, and she should be encouraged to come into the hospital for hydration and insulin management if she's really got bad hyperemesis or a GI flu or any of those things that might impair her ability to eat and therefore take insulin. It's a brand new world. Insulin resistance is much different. Glycemic targets are much different. Education starts at that first visit, and it will need to continue because it changes. And this is one of the most difficult things I find for my type 2 or my type 1 diabetics is what worked for them last week doesn't work this week. It's very frustrating for them. And then finally, I'll want to establish the diabetic class so that I can sort of signpost for her what her complications could be. We get into second trimester, we really want to prevent hyperglycemia because this is when growth is being set, especially in the late second trimester. So good glycemic control at that time may decrease your macrosomia rate. And again, because of insulin resistance, you really need to be using the postprandial values there. Again, hard for patients who are on a pump, not necessarily for the gestational diabetics. Want to prevent urinary tract infections that are associated with high sugars in the late second, early third trimester. Continue to educate them about these upcoming changes in their sugars because otherwise they will be very frustrated that diet and exercise is no longer doing it for them. Let them know that there's going to be an increasing need for insulin during this early third, late second trimester therapy. Late in the third trimester, you can even see tripling of insulin requirements as you get through the second and third trimester. Very important, especially for the pre-existing diabetics to know. Third trimester, everybody's afraid of a stillbirth. With good glycemic control and antepartum testing and surveillance for preeclampsia, those risks are actually extremely low. They are best prevented by using fasting and postprandial values for setting your glucose control targets as opposed to using the premeal values. You want to prevent macrosomia and traumatic birth. You want to prevent neonatal complications because the ideal here is your patient delivers at term vaginally, a healthy baby who goes home with her on day 1 or 2, preferably day 2 when she's had a chance to be educated. That's the goal. And so if your baby goes to the NICU for low sugar or jaundice, that pair won't go home together. Now, let's talk a little bit about third trimester and stillbirth, which is where everybody is obviously concerned about because you cannot recover from a stillbirth. You can recover from some of these other things, but you can't recover from a stillbirth. And in the U.S., background rates are anywhere between 3 and 7 per thousand. There are ethnic groups that are at higher risk, but that's the general range for the general population out of the 2015 numbers. In the diabetic population, those rates are higher, but you can stratify those based on how sick someone is, how severe their disease is, so to speak. Type 1 and type 2 diabetics are listed in this slide. This is actually looking at England, Wales, and Northern Ireland, and again, older data, but you can see what the stillbirth rates are then as you move from being a type 2 diabetic, which is on the right side of the screen, to being a type 1 diabetic, you can see those complication rates will increase. Gestational diabetic patients have much lower stillbirth rates if they are well controlled. And if you look at ACOG Committee Opinion 764, which just came out in February of this year, you will see that early delivery before 39 weeks is not recommended for the well-controlled gestational diabetic because the stillbirth rates are so low. Now, the third trimester goals, Landon study was a landmark for this, looking at the control groups and then the groups who required therapy with diet, exercise, and home glucose monitoring. He looked at the composite morbidity rates in this study. And what he found was that when you've got mild gestational diabetes, treating patients decreased complication rates for large babies, NICU admit, cesarean delivery, hypertensive disease in pregnancy, and improved maternal weight gain, similar to the slide I showed you earlier. And so the way that you achieve those decreased risks is recognizing it, recognizing those risk factors, doing the screening at the appropriate time, most importantly, stepwise management and team approach. You must have your team all on the same page. And if you have your team in one physical location, it's ideal. When I was working in California, I had a situation where my biggest referrer, myself, and my diabetes education center all had open doors, and we could slide patients from one area to another, or we could put her in one room and we could come to her. So that was really ideal, and not everybody's going to be able to have everything on in a one-stop shop, but the better you can manage that, the more your patient is going to appreciate it and respond to your therapy. You have to get her to recognize those rational goals, and then again, you get some bonus points if you can raise awareness of her long-term health risks. You need to look at her meter, in my opinion, at every visit, because patients want to please you with the log, and you need, at least on those initial visits, to set the expectations that, your meter is really reflecting what's going on. Your log may reflect your hopes and dreams, but we got to deal with your realities. So I think looking at the meter yourself is extremely important. Once you've established what those goals are, then you can go over that review. And then you need to be very non-judgmental in assessing how well she's doing this. No one likes to be, quote unquote, called out or yelled at. And so this needs to be something that you deal with, and do this in a non-judgmental way. Involve her in the review. Get her input as to what she feels will be the appropriate buy-in for that. Again, stepwise, team. You need a diabetes nurse educator. You need a dietitian. You really would have a lot better outcomes with social workers who can help with things like diet plans and meal plans and housing assistance and transportation. Experienced healthcare provider, it can be a midwife all the way up to an MFM. You got to coordinate with your primary care MDs if you're using endocrinologists. And then pretty much you're going to start everybody with diet, exercise, and home glucose monitoring as an initial review. Clinically, what I usually do is look at that within a week or two of starting therapy. And then if they're doing well, I'm going to look at them every week or two from 24 to 28 weeks gestation, reminding them that this is a period where their control is going to increase. Reviewing glucose values every 2 weeks, again, for those who are doing well from 28 to 36 weeks. I'm doing it twice a week for patients who are struggling at this point. And then from once you get around 36 weeks to around 40, I'm usually reviewing these weekly. My goal clinically is that they be able to perform home glucose monitoring at least 80% of the time, and at least 80% of the values should be within the target range. If so, then clinically what I usually do is continue them on diet and exercise. In the 70 to 80% range compliance, 78% target range, I will talk with her about what strategies she wants to put in place for improvement, and I'll allow a short period, not more than a week, until that next evaluation. And if that hasn't improved, then we need to talk about moving on and adding medications. Now, again, patients who've achieved good control, they're on diet and exercise alone, and who do not have other complications, do not require antepartum testing or delivery prior to 40 weeks gestation. They do not require an early term delivery. They do not require that you have ultrasound estimates of fetal weight. The data on the early term delivery and the antepartum testing, again, you can find in ACOG's recent practice bulletin 764, and 7065 is the other one on that refers to that as well. Looking at the risk for stillbirth, I alluded to the fact that it is really not significantly increased for patients who are under good glucose control. So ACOG will tell you expected management is okay and generally appropriate up to at least 40 weeks gestation. If they're on medication, again, the recommendation is 39 to 39 and 6/7 weeks delivery, but not earlier than that. In patients with poorly controlled gestational diabetes, delivery gets to be possibly earlier, depending on whether they've got preeclampsia or other things going on as well. But late preterm delivery is not the standard of care for these patients. Again, let's talk a little bit about medication, because this is something that has changed fairly significantly in the last few years. Again, I lived through the era when insulin was the only thing we used, to an era where 2/3 of my patients were on orals, back to at least 90% of my patients are back on insulin. And there are people in this audience who've had the same experience. So essentially what we've got to do is get a stable pattern of diet and exercise prior to starting medication. Got to talk to your patients about hypoglycemic episodes. I cannot tell you how many patients I have said, no, you cannot drive to school and pick up your children if you took your insulin and haven't eaten for the last 18 hours. You can't do that. Again, make it very granular for them. Once you start medication, you've got to establish the timing of the next visit and let her know when you're going to see when her therapy needs to be changed. Now, oral agents that are out there are glyburide and metformin. Insulin, there's a standard twice-a-day NPH regular mix. I bring this up because a lot of people are using the more expensive insulins. Insulin being $125 to $150 a vial now for some of the newer insulins. If your patient cannot afford those newer insulins, these cheaper, old reliables are still out there and they work really well. TID 3 times a day, NPH, and then Humulog before meals, 3 times a day Humulog, and Q hours sleep. Again, there's a bunch of different regimens. You and your group find out what works best for your patients. We will be talking more about these medical therapies in the next series of lectures that we're going to be doing. I just wanted to give you a taste for these for right now. Here is our reference list. You will find each of these references in the various slides. I hope the print and the type here is large enough that you guys can read these. So this will conclude our current lecture on diagnosis and initial management of gestational diabetes. We will have a follow-up lecture, and in that we will explore those topics of medication and management in much more detail. I thank you very much for your attention.